Yeah, apologies for this little glitch. I wanted to record this webinar. As you know, traditionally now we record the webinars and post them on the ADVAC website. And for some of the webinars, we had in excess of 4,000 people viewing the recording after the webinar. So, wholehearted welcome to all of you for this very important topic on the impact of the COVID-19 situation on the immunization programs, and with the assumption that unfortunately the impact has been deleterious in many places, how to correct the situation. So we are blessed to have two great presenters today with us, Richard Mihigo and Magdalena Bastias. And we have also a rich panel of experts from different regions in the world that will be able to complete the presentations and participate in the discussion. We will hear first from Richard. I will open then for a few questions directly in relation with the presentation. Unfortunately, Richard, for family reasons, will have to leave after 1 hour. So it's important, if you have very specific questions for him, that you can ask these questions before he goes. Then we will have the presentation by Magdalena, and we will open in full for the discussion. To remind you that the rule of the game is to have the questions sent in writing in the question and answer box. This time we will try with Carol, who is next to me, to improve a bit and try to see if we can let you directly ask your question, and we would have to move you in the panelist mode so that you can ask the question. So we will try it. If it fails, then apologies, and we will go back to having to read the questions for you. And the questions will be directed to the presenters and, of course, to our panel members, who will also be able to, following the two presentations, to directly give their view on the topic. So without any more delay, I would like now to introduce our first speaker, Richard Amigo. Richard is a native of Rwanda, where he was in charge of various important positions in the Ministry of Health, including that of immunization manager. He then joined WHO, and in 2014, he became the coordinator for immunization for the African region of WHO. And since the COVID crisis has certainly been on the forefront of supporting the countries to face the COVID crisis. So Richard has really a wealth of experience in public health for over 25 years. So on to you, Richard.
Okay, thank you very much, Philippe, and good afternoon, colleagues. I'm very much excited to join you this afternoon for this, I hope, which will be a very rich exchange and discussion on the impact of COVID-19 on immunization program. I will provide more the situation on the African region, how we have tried as much as we can to deal with that situation and the prospect that we are seeing from the future. So I'm going to share my screen for the presentation. So I hope you can all see my presentation.
Yes, this is perfect, Richard.
Excellent. Thanks, Philip. So I'm going to start by just giving you an update on the COVID-19 situation on the African region and the rollout of the EPI, the vaccine, COVID-19 vaccine in the region. And the reason why I wanted to start by this, we have been in this COVID-19 pandemic for now more than a year. The attention, the support, the focus of the technical support that we provided to the country the last couple of years has been now shifted and diverted really to support countries in the rollout of the COVID-19 vaccines. But before I go down to that, I would like just to give you a snapshot on where we are. This is the situation for the 47 countries in the African region. It's not the whole situation in Africa. This is the region that we, as WHO Regional Office for Africa, are covering with close to 3.5 million cases and close to 90,000 deaths across the world. Just 1 second. Just Philip, 1 second.
Sure, no problem.
Yes, just 1 second. Okay, sorry for this interruption. So we have close to 3.5 million cases, but when we take the overall Africa, we are around more than 4 million cases now and close to 130,000 deaths. Fortunately, we have a recovery rate around 80%. And since a few months now, we have started to roll out the vaccines on the African continent. Close to 49 million doses has been so far delivered in Africa, with 51 countries that have already started to roll out COVID-19 vaccines.
No.
Philip, can you please? Okay, thank you. 51 countries that have started to roll out the vaccine, with 4 countries that are still yet to deploy COVID-19 vaccines. These are Burundi, Tanzania, Eritrea, and the Republic Arab Saudi Democratic. After 4 months of the delivery of the vaccine, close to 31 million doses has been administered, which represent close to 65% of the dose that has been received that has been so far administered. Now, when we compare the situation in the African region and the situation globally, there is really a huge discrepancy. While we have seen, I believe, close to 2 billion doses of COVID-19 vaccine that have been administered throughout the world, which represent close to 25 doses administered per 100 people globally on average, and this can go up to 65 doses administered per 100 people globally. In Africa, we have so far only 31 million compared to 2 billion that have been administered globally. It represents around 2.3 doses per 100 people. And when we know the situation in Africa, the majority of the doses has been administered in Morocco. If you exclude Morocco out of this picture, the situation becomes even worse. So we are around 1 dose only that has been administered per 100 people. So we are currently working and trying to see how to increase the uptake of the vaccine, but also the supply in the African continent to make sure that we can reach the same level of delivery like what we have seen in other places. But I won't really go much into the details of that because this is not the topic of this presentation. Hopefully we'll have the time to give you more details on COVID-19 rollout in the future. But looking at the disruption of essential health services across the board, unfortunately, 1 year into the pandemic, 1 and more year into the pandemic, we have seen that the disruption still persists across the region. And when we looked at, we have conducted a survey across all the countries to try to understand what have been the impact of COVID-19, not only on immunization, but first across all the main programs. And you can see on this graph that pretty much most of the program have been negatively affected by the COVID-19. With mental health, for instance, 53% of countries in the region have reported disrupted services. 48% of countries reported disruption to immunization, NTDs, NCDs, reproductive maternal health. So basically, no major program have been left aside with this tendency. So if we zoom down into the immunization services per se, the same survey, which we conduct almost every 6 months to try to understand how countries are coping with the current situation, we have seen that close to 54% of countries have reported disruption to routine immunization services, whereas 43% of countries have reported disruption in terms of facility-based services as compared to outreach services. When we know that many countries rely on supplementary immunization activities, campaign to fill the gap, either to prevent outbreak like polio, circulating vaccine-derived polio, or even to have preventive mass vaccination campaign for diseases like measles, meningitis, yellow fever. This has been also very much affected. And if we looked at the graph here in this table, we have close to 23 campaigns that have been postponed last year. And mainly these campaigns were polio, with the introduction of IPV, measles, rubella campaign has also been postponed, meningitis campaign as well. So clearly we can see that no services being essential routine immunization, but also preventive mass vaccination campaign have also been disrupted. So we are trying now to understand the impact of this disruption on the routine services and how we can start preparing for the occurrence of, we never know, future vaccine preventable disease outbreaks that may occur because of these disruption. So trying to zoom down a bit on the essential services beyond immunization, we have tried to understand from the supply, from the demand side, what has been the factor that has affected really that disruption. And as you can see, countries are reporting different reasons for the disruption that could be linked to and mainly to staff deployment that have been diverted to provide more support on COVID-19 rollout. But we have also issue related on the demand side, where misinformation, rumors around COVID-19 vaccines have not spared routine immunization as well. So we have community fear, mistrust around COVID-19 vaccine that has got some implication, and people not visiting health facility for the fear to get the vaccine. And in some countries, these control measures that have been put in place, physical distancing, wearing of masks, may have also increased the barrier, particularly when health facilities are not very well equipped with commodities to make sure that immunization can be carried out in a much more secured manner. So we have tried to understand and document what have been the challenges, but also the lesson with COVID-19 vaccine rollout that have had some influence on provision of immunization services. I'm not going to go into much detail on that, but just to give you a few hints and ideas on how this has really affected service provision. Let me start by the multiple vaccines in the country of COVID-19. We have countries that have got several vaccine, Pfizer, AstraZeneca, Sinopharm, Sputnik V, and creating a bit of problem with schedule and interfering with the confidence that people had on routine immunization, because they're not, the communication in some countries have not been optimal to make sure that people understand very well which vaccine they're going to get, being for COVID, but or vaccine that they're going to get as part of their regular immunization programs. There have been a lot of issues with costing and financing, and all of that have created some vaccine hesitancy due to misinformation, rumors, disinformation. And that's, unfortunately, we've seen the situation with adverse event following immunization from specific products like the AstraZeneca vaccine, for instance, that has had some impact on how some countries have put that in balance with regards to provision of regular immunization services. Safety monitoring has impacted the regular vaccine delivery, as well as the line that have become a bit blurred between the target population. For the last 2 to 3 decades, most of the immunization program have been strong enough to provide vaccination for children. We know that we have moved to a situation where the second year of life have been also an issue. But now with the adult population that's now being vaccinated, I think it become quite different for healthcare workers to differentiate who to target, not only for COVID, but also for the regular routine immunization. Knowledge management, the different tools that we have used to make sure that vaccinated are very well documented. And I think all of that have to some instances impacted the provision of routine. Now, to conclude maybe this part, we have tried to see how countries are putting in place strategy to try to adapt this new normal by putting in place not only a delivery mechanism, other strategy to try to restore confidence in immunization, and then to see how we can quickly catch up vaccination. So on this graph, you could see that more than half of the country, close to 64% of those who have been approached have reported that using community communication, using local influencers, but also additional staff recruitment have helped them to overcome some of these service disruption that we've seen across the board. Countries have also redirected patients to alternative care facility to make sure that few clinics where immunization was provided, and particularly we have seen the opening of huge vaccination center to provide COVID-19 vaccines, which have to some extent diverted the attention to the provision of the regular routine immunization that were either provided into the clinics or in outreach sites moving forward. So we have tried, particularly here in the African region, to try to anticipate what could be in the future system that we are going to put in place to support countries to adapt to this new normal. And here I would like to elaborate a bit on 3 to 4 areas. The first one is in data systems. We definitely have seen that the existing data capability that we have for the moment didn't cope very well in not only managing essential routine immunization services, but also to cope with COVID-19 vaccine rollout. So optimizing data collection, analysis, and particularly management tools, notably using electronic device, electronic register, cell phones, new digital tools to capture older age population and adult population have been something that very instrumental moving forward. Secondly, in terms of human resources, we have seen that the number of health care providers and their skill sets were necessary to be upgraded to make sure that the healthcare workers can cope with this new situation, and particularly to bring new profiles, particularly in the area of infodemic management, trying to understand the issue related to non-communicable diseases as well as chronic disease linked to immunization, has led to stimulate a new approach to human resource capacity building moving forward. The third area that we are learning quite a bit, a lot of lessons, is the area of cold chain infrastructure and supply chain at large. And I think this has been quite very important to see how the current established capacity, which in many countries has been designed to cope only with infant immunization, can accommodate not only the regular routine immunization, but also new vaccines, including COVID, because we believe that we are definitely going to be in this situation for close some time now. And more importantly, how do we make sure that the essential health services are repackaged such a way that they can meet really the new emerging needs that the population has now expressed, notably to include in the future widespread routine adult vaccination, providing, for instance, booster dose for routine immunization, targeted adult population with specific antigen, and incorporating this into the immunization program across the countries. Looked at the service delivery into, for instance, schools, particularly for adolescents and young people. Reimagine or re-engineering the service delivery model, including the non-traditional sites that we have seen, notably in the workplace, in public health gathering sites, that could potentially be used in the future to try to understand how we can optimize our reach to the population. And then finally, how to address really the challenges related to older age group and adult population, so that a more comprehensive package can be provided to this group of the population. They can come to receive immunization, but at the same time, respond to other public health needs that they may express. And we believe that all of this should, in principle, lead to a more rethinking on how the primary health care system is organized in the different countries. The third part of my presentation is linked to to zoom now down on routine immunization. So in Africa, we've come a long way the last 3 to 4 decades, where immunization has increased quite substantially, as you can see, from the early 80s to reach a peak in the 2000s. But since almost a decade now, we have seen a sort of plateauing of immunization coverage. And while we were reflecting on how to help country, support country addressing this overall plateauing of immunization coverage, then COVID-19 started its effects. So we have tried here to compare using the WHO immunization WENIC data, estimate of coverage 2020 to 2019, because we have full set of data for 2020. We are seeing that the marginal decrease of coverage in 2020 were really marginal. And one of the reasons for that, after the first 6 months that we went through in 2020, during lockdowns, during restriction of movement of population, the second part of the year, we saw a lot of activity in terms of the catch-up that has really increased the coverage to come pretty much to the level that we have seen in 2019, which is, by the way, it's a very positive thing, because we were quite very concerned around June, July, to see the drop that we have been witnessing in 2020 compared to 2019. When we looked at some of the granular process indicator in terms of, for instance, immunization session that were planned, in terms of outreach session versus the one with the planned activities versus the implemented, we saw that in 2020, this is where we heard a quite huge drop. The pink color showing the outreach activities in 2020 compared to 2019. And that is obviously something we can understand very well because of the lockdowns and movement restriction that were done. But later on, we saw a quite an increase in terms of catch-up activities that started. And this is very much seen on these bar charts, where for 2020, we have seen a sort of drop in terms of, particularly when it comes to the starting in June, July, in terms of number of sessions that were interrupted in Africa. And I think this was important to understand where really the bottlenecks were lying in terms of addressing the specific needs of the country by monitoring these type of indicators to understand exactly where the situation were getting worse and how additional input and resources could be brought on board to try to address this. We also looked at vaccine availability in terms of stock outs or not. Did we see any difference between 2019? This was the period pre-COVID in 2020 and even now. The good news is that in most of the vaccination sites that were visited using our system, pretty much 3/4 of the countries and sites that were vaccinated did not report any stock out of the vaccine. And that may also be linked to the fact that the system of provision of the vaccine through Gavi, for instance, though slowed down a bit, but did not go through a major issue. So at least there is a very good news in terms of vaccine availability. And we have seen that that has played a key role when countries started to roll out strategy to increase coverage. So to really conclude, I wanted to summarize the issue I've highlighted in this presentation by first saying that the disruption that we've seen, indeed, as I've shown on the previous slide, are still persisting, though a country have largely opened up their economy, meaning that current disruption may not necessarily be associated with the lockdown of burden of COVID-19. So this is something that we are trying to investigate quite very closely to see how, moving forward, we are going to adapt to this new normal that we are living in today. And of course, this suggests that there is residual effect of the pandemic on essential services will really persist probably for a long time before we go back to a normal situation, hopefully when many people will be vaccinated and activity will start to be rolled out without any problem. With regards to disruption, as I presented, we saw the situation in both the demand side, but also the supply side. And strategy have been taken to address those disruptions from the demand side by increasing communication, increasing demand, trying to put in place a more aggressive infodemic management, and trying to really to debunk all the false rumors that we are seeing for the more currently on the social media. On the supply side, we've seen that countries have increased healthcare workers, They've increased the availability of vaccines, as well as diversified the skills and the profile of the people now who are currently involved in service provision. Indeed, some gains and partial rebound in service provision have been seen, as we saw, and these were really due to the implementation of some of the recommended policies that we put in place right at the beginning of the COVID-19 to try to minimize as much as we can the pervasive effect of COVID on routine immunization. So I'll stop here and thank you very much for your attention.
Well, thank you very much, Richard. This was really a terrific presentation, and you covered so much ground in these few minutes. I mean, part of your presentation was actually quite sobering when it comes to the equity of COVID vaccine access in Africa. I think these figures that you presented early on were really striking. You then took us through the impact of the efforts by the various countries and WHO in Africa to keep the immunization program afloat. And then finish with a note of optimism in terms of hopefully the positive legacy of this crisis on the immunization program. Perhaps let me ask two questions, and then I'll turn to Marie-Rosette, who is coming up with a few questions on your presentation. But the 2 points I noted in your presentation, Richard, the first one is you indicated that the immunization programs were among the hardest hit programs. However, it was only, if I'm not mistaken, 48% of the countries in the region which reported the immunization program being affected. And that surprises me a bit. I would have expected a larger proportion of countries to be affected. So is that underreporting, or is that definitely countries had an immunization program that was really protected from impact by the crisis? And the second point I wanted to raise with you, there obviously have been much efforts by the countries, and you alluded to that, in terms of funding and allocation of resources. Do you anticipate that in the future, people will see better what immunization can do for them, and that the politician will invest more in preventive care, and particularly in immunization services in the region? So I will first ask you perhaps to comment briefly on these two questions, and then I will turn to Marie-Rosette to ask her question.
No, thank you very much, Philippe, for this question. Let me start by your last one. Well, I wish we see a renewed interest, a renewed momentum on increasing investment on immunization and etc. But when we looked at all the preliminary signs as of today, nothing is pointing out in that direction. Unfortunately, I think, and to link that with your first question, clearly, one of the, I believe, the positive effects that we've seen during this crisis was the resilience of immunization programs across the board in many countries. From most of the preventive public health intervention that we have implementing in the countries, we know very well that immunization is the one that has got the highest coverage in terms of preventive. So there was a sort of established resilience for immunization services. Indeed, this was very much challenged in the first week of the pandemic, with the lockdowns, with movement restrictions in many countries. People couldn't go to the clinics. And I think that was the case in many other places. That as the lockdown started to be lifted out and people are resuming slowly their day-to-day activities, we saw as well a sort of progressive resumption of immunization service, at least in terms of the fixed site immunization and not the outreach. And I think this is why you saw that we do have even some interesting data that we we collected on a month-by-month basis, where we see that how indeed the services went down around March to June. And then from June to September towards the end, we saw a much more recovery being kicked in. And we have tried to understand why this situation happened. And I think one of the reasons we found was, number one, the fact that parents still believe in immunization. And even in countries where we saw quite some high resistance on COVID-19 vaccine rollouts, this has not affected much the confidence that the parents had on routine immunization. So there was kind of vaccine-specific hesitancy linked to COVID-19 vaccines, whereas the established immunization programs that have been running up for many years were quite more resilient. And just last month or 2 months ago, we had a very interesting case in the Democratic Republic of Congo, where in the middle of the COVID-19 vaccine rollout, we conducted a preventive mass vaccination for yellow fever campaign. While the country was struggling to get the COVID-19 rollout, we were very much delighted to see how population came quite in mass to receive their yellow fever vaccines, which was already establishing the knowledge of the people and etc. So I think, Philip, that could be the explanation that I can provide at this stage. Number one, the resilience of the system. Number two, a lot of efforts that were done to put in place policies, guidance on how country can safely resume routine essential immunization services, and a big emphasis that was put on social mobilization and community involvement in that. Over to you.
Thank you very much, Richard. Very interesting answers, and to know about the resilience of at least of the well-established routine immunization programs in Africa. We were trying. Sorry, I was interacting with Carol here to know how we could manage moving people on video who want to ask questions, but it seems that we're having a few challenges here. So unlike what I said, I'm afraid I'm going to have to read the questions of the participants for you, because otherwise we're going to lose too much time in the interaction. So let me then throw the first question of Marie-Rosette Naimana, which is there an increase of VPD's outbreak in the region that may be associated with the disruption of immunization services? And where this disruption associated with this outbreak? So I guess you have alluded to the potential of outbreak, but not to the occurrence of outbreak. So the question is pushing you to be a bit more specific if we have already observed outbreaks or not. And then I will have another question from Marie-Rosette.
Thank you, Philip. For the occurrence of outbreak, we've seen a mixed picture, by the way. We had in the past.
I'm having difficulties to hear. I don't know if it's the same for the other participants. All of a sudden, your voice is getting a bit watery.
Can you hear me now?
It's difficult. We can hear, but before it was perfect, and now it's not optimal.
I think it's my internet connection. I don't know if
might be.
So let me try very quickly. So I was saying that we have seen a mixed picture. For instance, the circulating the CVDPV that were already in a few countries. We saw that even measles, when we went through the severe lockdown in many countries, the opportunity for transmission, the opportunity for people getting together were reduced, and then we saw to some extent the limitation of these outbreaks. But we know very well from the past experience in Ebola, for instance, in 2014, that after the major Ebola outbreak in West Africa, there was quite an upsurge of measles cases. So this is something that we are currently very much monitoring, but we have not seen the type of huge outbreak that we went through in 2018, 2019, which saw DRC, Nigeria, Madagascar, and many other countries witnessing huge outbreaks. So in those countries that could have been susceptible, probably some of the pool of susceptible children were depleted, were probably already affected. But this is the situation that we are currently monitoring quite very closely. The hygiene measure that have been put in place could have also limited, and we saw that the incidence, for instance, of diarrhea diseases, infection, respiratory diseases in few countries. But I would like to stay on the cautious side, that we are still increasing our surveillance, which we are also affected by this situation, to try to understand the true picture of vaccine preventable disease circulation in many countries.
Thank you, Richard. The other question from Marie Rosette was that she was stating we might need to understand the factors with the current disruptions while lockdowns have been lifted. So why is it, in a question that we're still seeing an impact when the lockdown measures have been lifted? And are there any ongoing investigation to understand the problems? I believe you have in part answered the question talking about some of the hesitancy factors that were created by some of the decisions in countries, but I will let you elaborate a bit further.
No, absolutely, Philip. I think beyond immunization, I think what this really pandemic has taught out is the resilience of the several health systems in many countries, where the confidence in health services, the fact that the people were not able to access the services, even in the pre-COVID-19 period, clearly has been largely indeed exacerbated by the situation that we are in. So we are trying to unpack some of these reasons and then try to see how, not only from the immunization point of view, but also from a primary healthcare perspective, on how to try to understand and to address some of these issues, not from the immunization angle alone, but really to understand what makes people come to the facility, what makes people be more confident to the system. And I think this is one of the last slides I provided. What are the future of primary health care, where immunization could play a critical role? And I believe it's important here that when we come out from this COVID-19 pandemic, we design programs that are completely different, that are not too vertical, but where are relying on the strength of the system in place, so that the different shocks that we are going to see on the system cannot necessarily break the program as easily as possible.
Thank you. Let me then take just one more question from Tracy Evans-Gilbert from Jamaica, and which borders the previous question on the issue of outbreak. And she's saying, with respect to measles, less cases have been reported in some countries. And she's unsure if this is underreporting or the fact that the public health measures, i.e. the lockdown and also similar measures that limited transmission. So she's asking if you saw less measles in Africa.
Well, this is what I responded a bit. I think the pattern that we are seeing for the moment is not different from what we've seen in the past. Indeed, this might be a bit truncated, as I said, because in some of the bigger countries, Nigeria, DRC, we went through a major outbreak in 2019. Ethiopia which is the second most populated country, conducted, fortunately, in July, in August, during the COVID-19, a preventive mass vaccination campaign against measles, where millions of children were reached with all the preventive measures implemented. So there were a lot of activities that were conducted even during the COVID-19 that has helped to minimize the occurrence of expected huge outbreak that one would really fear about that. But we remain very much vigilant to try to see, and fortunately we have 18 countries that are currently submitting applications to Gavi for preventive mass vaccination campaign against measles. Others are in the process of conducting mass vaccination campaign, because we know very well that if nothing is done in the next couple of weeks, month, or next year, we will definitely see a huge proportion of children who will become susceptible and definitely prone to outbreak. So this is the strategy that we are currently using.
Thank you very much, Richard. I will perhaps stop it there. I mean, there are many more questions that have lined up, but I mean, some of the questions then will probably overlap with the next with the topics raised in the presentation by Magdalena, and we clearly need to release you before too long, Richard. And Anna's connected, so she will be able to answer some questions related further to your presentation. So thank you, many thanks for this great presentation. Thank you. And let's then turn to you, Magdalena. So Magdalena Bastias is a member of the Global NITAG Network Steering Committee in her country, in Chile. She's actually the executive secretary of the Chilean NITAG. And she's a part of the Ministry of Health, of the Immunization department, and works much on evidence-based decision making, and also specialized in epidemiology. So Magdalena, you will tell us now about the impact of the situation in your own country, in a different region of the world. So thank you.
Thank you, Philippe. Good morning, good afternoon, and good evening to everyone. Thank you for inviting us to present today here at this webinar. So I will be sharing with you the country perspective on the impact of the pandemic on a immunization program. Let me check that I can. Okay, so this is what we will be discussing today. So briefly, I'll tell you about Chile's national immunization program, and then we're going to dive through these three experiences, or at least three sides of the impact of a COVID pandemic on an immunization program. So some of the deliverables of our immunization program, this is a list. Let me just check some of them with you. Of course, we aim to contribute to the eradication of vaccine preventable diseases, and also aim at a vaccination coverage of 95% to reach it and then maintain it. And we are lucky to count on a national immunization register that allows us to monitor it closely and systematic on real time. And we also work daily to strengthen that national immunization register. It's very important for our program, the accountability of the immunization network for the different levels involved in this network. We also work on adverse event surveillance and immunization errors surveillance separately. The communication with the public and transparency is very, very important. We work on that daily, and ensure safety of biologicals, of course, and to establish strategic alliances with other programs within the region or between regions. So, as I mentioned earlier, regarding the impact of the pandemic on immunization programs, there are many sides to this. And I'm going to share with you 3 of them that we have observed and worked on so that we can share them with you. So let's start with 2020 seasonal influenza vaccination campaign. So then we say, like, why 2020 influenza vaccination campaign? Well, first of all, our seasonal influenza vaccination campaign takes place between March and July each year. So now you can see that it was actually taking place while the pandemic and the epidemic, right, was just an outbreak here last year. So first, to share with you that in Chile, this campaign is implemented annually since 1982 with the aim of preventing deaths and serious morbidity, of course, and with the aim of preserving the health system integrity. So naturally, there's been an annual increase of influenza vaccines made available during the campaign after taking into consideration local demographic and epidemiological changes, and also new evidence that guides you on changes in the campaign each year. So if everything was okay, then what happened in 2020? Well, the seasonal influenza had to be replanned while in progress, because new high-risk groups to be vaccinated were included in accordance to the pandemic health alert requirements. Okay, so the national immunization program managed to increase the available doses of influenza by nearly 20%. And I said managed because it was a difficult time to get new doses for that period where the rollout of the influenza vaccination takes place. It is the countries in the Northern Hemisphere actually planning their campaigns and getting their doses. So it was a difficult time. It was a big challenge, but the immunization department managed to increase the doses to guarantee the access for these new high-risk groups. So far, that looks great. So then what was the next challenge that we didn't foresee, but we had to face? Seasonal influenza risk groups were called on to adhere to vaccination, to influenza vaccination promptly. So in this way, they would avoid co-infection with COVID-19. So let's see if people responded to that call. So I'm sharing with you this graph. It might look a little bit weird to you, and you are right. You will see why. But just let's focus on these 2 curves, which is the how the influenza, the accumulated influenza uptake took place during 2018 and 2019. Those are similar curves. And this is what we were used to see in pre-pandemic years. However, let's see how 2020 was. This is what we faced during 2020, an incredible demand for vaccination during the first 2 weeks. And actually, let's zoom in into that part of the black curve, which is 2020. What did it mean to the immunization program? It meant a 4-fold increase in demand. So the maximum demand of doses per day used to be around 200,000. And during 2020, we even got a day where 800,000 doses were demanded. We managed to give all the doses that were asked from the program across the country. However, that was not a scenario we would like to repeat, and that is one of the things we learned. So as one of the lessons learned, that we didn't want this kind of demand to be repeated in the future, the idea of scheduled access started to be considered. And this year, the 2021 seasonal influenza campaign has been coordinated by the state level, the central level, with the use of vaccination calendars. And the groups were stratified by risk groups, let's say age, or if those groups belong to essential occupations, to the health system, or to the state, comorbidities, etc. And also, the planning of the seasonal influenza campaign 2021 considered the new risk groups that were introduced just in the middle of the campaign last year. So that allowed for planning, and we were prepared to include that population this year. So the second experience, or a second side of the impact of COVID, the COVID pandemic, is on routine immunization. Richard gave us a great introduction at a regional level. So we are going to share our country perspective on this. We could actually analyze our data. We compared the routine immunization coverage during 2020 with the average coverage of the period between 2015 and 2019, that it's a 5-year period. So to have more stable numbers there, right? So we observed a decline in routine immunization during 2020 across all recommended ages and all vaccine products, for the exception of pneumococcal vaccine in adults. And when I hear talk about routine immunization, I mean infants, toddlers, school children up to 12 years of age, Tdap during pregnancy, and adult pneumococcal vaccination. So in this graph, you can see that the decline, although there's been decline across all recommended ages and vaccine products, with the exception of pneumococcal vaccination, the size of the decline varies by age and by vaccine product. So the minimum decline was around 0.3% at 2 months with the hexavalent vaccine, and the maximum decline was at 18 months, again for the hexavalent vaccine, and the second maximum was at 18 months for hepatitis A. We also observed the occurrence of non-simultaneous vaccination, especially at 12 months of age. We could see it with more clarity, since there are 3 vaccinations recommended at that age. And the size of the decline varied from 3.8% in the case of measles-containing vaccine, up to 8.7% in the case of meningococcal vaccination. So that's another lesson for us. And again, as the exception to this was the adult pneumococcal vaccination, which increased by 0.8%. So also Richard mentioned some of the factors that may be related to disruptions during the immunization access disruptions during the pandemic. Amongst them, reluctance to leave home due to fear of infection, domestic migration to spend lockdowns with family or in rural areas, and also health workers' redeployment to COVID response. With respect to the last factor, we consider that would not explain what we have experienced, since the national immunization program in Chile actually increased the availability of health workers deployed to immunization services during the pandemic and up to now. Also, this is a very important factor about to mention that the stability of the leadership and the accumulated experience of this immunization department has been preserved, for it hasn't experienced any changes in the past 5 years. So this team also could be considered as a consolidated one. What did we do when we're facing our findings? Well, a catch-up strategy on routine immunization was called on this year. So seasonal influenza risk groups that overlap with routine immunization target groups were called on to update their routine immunization vaccination status during the influenza vaccination appointment this year, 2021. What does it mean? So it means that we were aiming at optimizing the opportunity for routine vaccination in children from 6 months through 10 years of age, adults from 60 years of age and above, pregnant women, and people with comorbidities between 11 and 64 years of age. So we were inviting around 8.3 million people, those of them who had pending status of vaccination, to update their status during the influenza vaccination campaign. And of course, we have to analyze results after the influenza campaign finishes this year. And if further catch-up interventions are needed, we might implement a second catch-up only for children during the 2021 school extramural vaccination, which takes place every second semester of the year. And regarding non-simultaneous vaccination observed both at 12 and 18 months, of course, we want to know what's behind that. So we will be designing, piloting, and later conducting a survey among healthcare providers to explore the factors that could be potentially related to these missed opportunities of simultaneous vaccination, because those factors vary widely. We could be maybe facing barriers to reattendance, including those that actually stem from the pandemic control measures. Maybe there's need for education to parents regarding immunization, the importance of timeliness, or inadequate tracking of clients registered at the health facility, or other kind of deficiencies in vaccine monitoring, etc. So we want to find out, and we hope to be able to construct that survey during the second semester this year. So this third slide we're going to share with you today is the COVID vaccination campaign itself. So since it's a vaccination that's taking place, we're just in the rollout of this
vaccination. We planned this presentation around questions we've received so far. So I'll share those questions with you and what we found. So regarding challenges and successes that we've encountered in vaccine procurement, first, I believe that it's important to mention that all countries are facing these cross-cutting challenges that have to do with the time necessary for vaccine research and development, for the proved safety and efficacy, and after that, the limited capacity for vaccine manufacturing and international demand at the same time. So we're all facing that. So locally, a success we've been privileged of experiencing is that we were capable of diversifying the vaccine access opportunities, and that was through two, I list three channels here, or three paths, but they were actually more than rather two, and I'm going to explain why. So first, I mentioned here research and development collaborations between a national consortium of universities and vaccine developers. and the direct commercial negotiations between the state and the manufacturers. So some of those direct commercial negotiations stemmed from the research collaborations between local universities and vaccine developers. And secondly, then, to have joined the COVAX initiative under the optional purchase arrangement. Regarding logistical challenges, of course, we faced very many logistical challenges, as well as many of you have. And one of them, I think you may imagine, is the distribution of the Pfizer-BioNTech COVID-19 vaccine. We were not only facing a new vaccine, but we were also facing a new technology. So we are all aware of the needs of this, of the storage of this vaccination. So this is just a plot of the planning, and this was the real plot and real planning in our department. And just please have a look at all that it implied, all the different transportation systems needed and used for the distribution of the vaccine, so that it could be implemented at the least time possible. And all these efforts allowed the immunization department to deal with a vaccine waste of 0.5%, while the known range or acceptable range is within 5 and 10%. So this was also a success. Conditions around the Pfizer vaccine have been modified today. There's more flexibility, but this is what we were facing at the very beginning. Together with challenges, we have also gained new, good, useful practices that have emerged as an effect of preparing for this rollout, and originally then as an impact of the COVID pandemic. So that is the cold chain validation. I'm just mentioning 3 dimensions of this validations that are quite important and interesting. The first one is the cold room certification. So our cold room system has been always been monitored and working properly, of course, but it's a different thing to be expecting a product that needs to be stored at -70 degrees. So we had to ensure that everything was certified properly. And in September 2020 through January 2021, the cold room certification took place. It's installations quality, operational quality, and performance quality. That is IQ, OQ, PQ. Also, the creation or update of norms and protocols for vaccine storage and distribution best practices. Of course, we did have norms before, but this were tailored specifically for vaccine and immunization distribution specifically. Before that, they were part of the pharmaceutical products norms. So it was an important gain that we did. And third, a passive refrigeration standardization in the country. So the immunization department designed and manufactured isothermal containers and distributed them nationally to each vaccination point. So that was a gain as well. We all have faced, now we're going back to challenges. So we all have faced the need to prioritize access to vaccination, COVID vaccination. And so how was that process? Did we face any challenge in developing the effective prioritization? Well, it was a difficult process, of course, but actually the evidence-based COVID-19 vaccine prioritization recommendation was developed by the Chile NITAG, the way Chile NITAG and other NITAGs, of course, make their recommendations, and ultimately the decision is made by the Ministry of Health. So that was okay. It was a difficult process, of course. We were facing something new. It is difficult to make recommendations on preliminary evidence, and that actually cross-cuts all topics regarding COVID-19 vaccination. But the challenge really came after that. It was the reception by the external interest groups. So of course, you cannot make everyone happy, and that's why, and prioritization is a difficult scenario. We wouldn't like to prioritize, but we all needed to. And the lesson learned regarding the reception by external interest groups was that establishing communication with some of those actors was crucial, and it was again as well, because we could improve and actually update and make more comprehensive documents regarding the prioritization recommendation. So we again, and challenges here, we are still on prioritization plans. So again, one thing that we learned also during 2020 regarding the influenza vaccination, but here now we are in the COVID campaign rollout. There's also scheduled access to COVID-19 vaccination being implemented. And also the population is stratified by risk. And a frequent question we get, and everyone does, is how does the emergence of variants of concern affect Chile's vaccination strategy? And of course it does. It will if it needs to be considered, and if there are products that actually are proved to be effective and safe, right, against those. But so far, and as for all other vaccine preventable diseases, the local epidemiological context permanently informs the COVID immunization related policy decision making. And there's also SARS-CoV-2 variants surveillance in place. So that is permanently informing the decision-making around the COVID vaccination. What about hesitancy? Well, so far we've had high demand for COVID vaccination. In general, our approximation to vaccine hesitancy relies on different elements. One of them is the systematic and real-time monitoring of vaccine coverage that our National Immunization Register actually allows for. Also, the surveillance of adverse events on one side and the surveillance of immunization-related errors allow for the prompt strategic response to COVID-19 adverse events. And also, lately, Chile NITAG has released a guidance on immunization strategies against COVID-19 vaccines adverse events. Very important to address potential hesitancy is the permanent and transparent communication with the public. And that includes a daily TV report, actually by health authorities. What about our role in encouraging or supporting global distribution of COVID-19 vaccines? Firstly, again, we joined the COVAX initiative, so we are part of COVAX, and also Chile has collaborated at the regional scale with donating vaccine doses to neighboring country, and also by facilitating the distribution of vaccines to neighboring countries. So this is my last slide.
And this was a very easy question Philip asked me, kindly asked me to include in the presentation. So easy, right? What's the impact? I can't see the slide. So what is the impact of legacy that the vaccination campaign may have on the routine immunization program? So my first thoughts are here in gray, that this, the campaign, the vaccination campaign experience is in process of building. It's just something too new to us and to us all, right? So there are lots of questions around it that are unanswered, right? Will we need a booster dose? Will COVID vaccination be a seasonal vaccination? And if so, will it be universal or targeting specific groups? What about variants and vaccine products? For that, what will happen with the manufacturing capacity of COVID vaccines and the world or a global distribution? And again, the global access to COVID vaccines, there's lots of unanswered questions, plus globalization, right? And the economic side of life as well. So I have more questions to Philip's question, actually. But what I can say, and I think you walked together with me through this, is that so far, with the little experience we've gained new good practices that we have introduced into the immunization program, as I earlier shared with you. We have implemented corrective actions regarding routine immunization coverage. We still have to see the results of those strategies, the impact of those, but we are closely monitoring them. And this is again as well that our immunization department is currently undergoing an external assessment, and we hope to gain from that recommendations for growth, development, and strengthening. And I believe the long-term impact is yet to be seen. And I think this is my last slide. So thank you on behalf of the Immunization Department.
Well, thank you very much, Magdalena. Certainly another great presentation and very interesting to see the experience of a high-income country in contrast to the mostly low and middle-income countries in Africa. And there are some definite similarities and so many efforts that have been put in place. I mean, I find your investment in the efforts and the ability to deliver the vaccine so fast with all what has been put in place with the cold chain simply amazing. And I certainly hope that indeed there'll be a positive legacy as you flagged and you honestly flagged still the uncertainties. Let me invite all our panelists to open their videos so that we see them, and I'm going to turn to them and travel through the world. I'm first going to head up north from Chile and invite Melinda Wharton, who is the Director of Immunization Services Division at the Centers for Disease Control in the US to reflect on the presentation if she wishes, and share a bit of the experience on the theme in the US. So Melinda.
Thanks so much. So these were both terrific presentations, and I guess what struck me is how regardless of the difference in our countries, how we had so many of the same experiences related to the impact of the COVID epidemic on routine immunization services. Back in March and April 2020, when the pandemic began, we had in the United States a really dramatic reduction in delivery of ambulatory services across the board, all medical specialties, all ages. It just was dramatically reduced. And although that recovered over the next couple of months, we ended up with still a deep deficit in vaccination from that period that we still have not fully recovered from. The visits are, I think, pretty much back to normal now. If we look at our public sector vaccine orders on a week-by-week basis, it's pretty comparable to our comparison period from 2019, but we still have substantial deficits. And in terms of the causes, I think it's exactly the same things that both speakers mentioned. There's the challenges of healthcare workers. On the public sector side, our public health workers were generally diverted to working on the COVID disease outbreak response, and then later the vaccine program. So the immunization program staff that normally we would have relied on addressing this were generally not available. So we have tried to identify other partners who may be less overwhelmed by that to work with, but it has continued to be something we have not fully recovered from. We also have seen in our data the fear of parents to come into offices for fear of contracting COVID. And certainly early on, the issue with providers not having personal protective equipment, was an issue here as well. So really the same issues the other speakers raised, we absolutely have seen in the United States. The other issue is, at least for older kids old enough to be in school, we really rely on school vaccination requirements to be a behavioral nudge for parents to remind them that childhood vaccination is important and to get their kids vaccinated. And with so many schools being not meeting in person during the previous school year, or not being fully in person, or just the other competing priorities school systems were dealing with, enforcement and follow-up of school requirements just was really not very high on the priority list for many schools and public health agencies last year. So at the same time, there were some issues with service delivery, at least initially. There was parental reluctance. There also was not this separate push from the school system or the local public health authorities who enforce school requirements to get kids vaccinated. So with all of those things in place, we just have, we're still not caught up. Now, I think we're pretty hopeful that as our adolescent vaccination program for COVID is rolling out, and as we end up with schools going back into session in the fall, that we'll be able to get fully caught up. But I mean, we still have the same concerns that both of our speakers described in terms of impact on the routine program. So I thought they were both really terrific presentations, and it is a reminder of some of the challenges that routine programs faced globally with the pandemic.
Thank you very much, Melinda. And I would like to remind all participants that you can ask questions using the question and answer box, either in relation with the two previous presentations. I've already a few questions lining up, or comments. Or you may also have comments or questions for the panelists. I will now cross the Atlantic, the North Atlantic, and move to Switzerland. Actually, it's not Switzerland that Anne represents, but more the world, since she is the EPI coordinator at WHO, although previously she was in charge of the immunization program in Sweden. So, Anne, would you like to add your thoughts to these previous comments?
Yes, I think it was two fabulous presentations, and particularly I've been looking at Chile and trying to understand the challenges and how you managed to do this fantastic rollout. Chile is one of the countries that have reached the furthest. I think it's 94 per 100 population or something. It's like amazing starting from December and the ramp up. The question I have for you, Magdalena, is you still have a lot of cases. The pandemic in Chile is still not under control. So I wonder if you can reflect a little bit about, how you see that. Did the rollout, was it just you reached the greatest number in late rollout of the campaign, or was it stable during the whole period? So it would be interesting to hear your view. And if people also are questioning and thinking about this within the country. And I also wanted to know, Magdalena, if I look at, because we're sitting in the global database kind of and looking at what's happening with routine immunization as well as COVID-19 vaccine rollout. So when you presented the data on decrease in rollout 2020 compared to 2019, do you have any data about the impact on routine immunization of the rollout of now during 2021? Will there be additional decreases, do you think? So I'm trying to look at data that is coming from different parts of the world to see we have an impact of the pandemic for all the reasons that you and Richard was talking about, and Melinda, in all countries. But now we also have the quickest, vastest, biggest rollout of vaccines ever made. And will we then have additional impact on the routine immunization? I think yes, because resources will go there, staff will go there, and countries, particularly in low resource settings where the health care force is already stretched, it's going to be an increased, particularly in Q3, Q4, when the millions and millions of doses will be ramping up, not the least from COVAX. And then I just wanted to, Richard is not here any longer, but let me just expand on what he was talking about, because, and maybe boost a bit, for him, Afro has been extraordinarily resilient when it comes to impact on routine immunization compared to the other regions. When we early on, we put out pulse surveys to try to get the data on the impact of routine immunization, we saw a big dip, the same way that Richard was talking about, and you, Melinda, in March and April. The interesting thing is that Afro was least impacted and had the least dip of all the other regions. And it has been very interesting to see how very quickly across all the regions, there has been a resilience, a building back again, not to the levels of reaching all the ones that was missed, but still very much. So we're right now assessing the data from the global EGRF, which is the annual data of coverage from all countries. And so I'm holding my breath to see the final. We're lacking a few countries still, but really see the impact from 2020 on the pandemic globally, because we have seen a catch up in the later part of 2021. Countries have been building on their routine immunization system fantastically. And then just one comment as well. I think that the rollout has been possible of COVID-19 vaccine has been possible because we have routine immunizations that reach very far, right? We're building on those routine immunizations. It wouldn't have been possible if we didn't have that infrastructure from the beginning. But what we argue in WHO is that it's even more important now to build back better, to have strong systems, to reinforce the global health security, to build their logistics, build their healthcare workforce, to be able to respond to the next pandemic even better. Thank you.
Thank you very much for these comments, Anne, and the many questions actually you listed for Magdalena. So Magdalena, do you want to take a few of these questions? I realize some may be actually quite challenging.
Yes, thank you, Anne. So your first question was the preliminary analysis, or my opinion with respect to COVID vaccination rollout and the epidemiological situation or context of the COVID epidemic, right? I believe that as we all know, vaccination is one more measure for the, in this case, for the control of the epidemic. For our aim with the vaccination is to preserve the health system, to prevent deaths, and prevent hospitalization of severe COVID cases, right? So vaccination is one more measure, and that is how we can, that is our approximation to it at this point in time. For other measures are still very much needed, and we believe, or not we, my point of view is that those measures ought to be reinforced and are daily by this national TV daily report, and health authorities every day call for the population to keep respecting and implementing those measures. So I think the rollout of the campaign has been a success, though we need time for the vaccination impact itself to be, it needs time to be seen at an epidemiological context. And also we are all learning, because different countries have been using different products in their rollouts. So we are also learning the potential differences amongst these vaccine products also. Israel is an excellent example also of a COVID vaccination rollout, and they are mainly using a different product from what we have used mainly in our population. So that's an interesting learning also in process of building, that we are looking forward to learn from it and to see the results and the explanations behind it. So that is what I can comment on that question. The other question was about immunization coverage, and if you can remind me.
So the difference is, do you think you will see an even further decrease in 2021 compared to 20 due to the rollout?
Yes, thank you for the reminder. Well, we've scheduled to check on our deeply check on the immunization, routine immunization coverage by July, so that the first semester can tell us how it is going. I do know that the curves for the different vaccination products and different recommended ages are going well. However, a deep analysis like the one I showed you that allows us to compare is scheduled for July. You know, our school year and our year actually starts in March, you know, and finishes in December. So we have a different cultural rollout of the year life in a way. So that's why we plan it for a bit later. And I really hope it's not going to be even or the decline won't be greater than 2020. That is my hope, and I'm actually I'm very positive. But we do know, and we are aware we have lots of work. That's why we implemented the catch-up strategy during seasonal influenza, and we might, if needed, implement the catch-up during the school extramural school vaccination that takes place during the second semester also. So that's something we have to see. And I wonder if there was another question. No? Okay, over to you, Philip.
Thank you. We all need to be optimistic, to echo your point for the future. Let me move now to the next to Switzerland is actually Germany. So I will turn to Ole. Ole Wickman is working at the Robert Koch Institute and is for a federal state, what would be the equivalent of an immunization manager. Is pretty much in charge of what happens on the immunization front in his country, in Germany, and at the helm also of decision making when it comes to deploying the vaccines. So Ole.
Yes, thank you very much also for the kind invitation. I think these have been really excellent presentations, and I think similar to what Melinda said, it was quite striking, the similarities, especially to Chile and what we experience here in Germany. But also I think what Anne mentioned, that probably depends where the routine program is affected, depends on what has been in place before the pandemic. And what we see in Germany is actually for the childhood immunization, we're quite stable in the vaccine uptake. We had seen some delays during lockdown, but I think there's been a catch up. And in Germany, you need to understand that the delivery of the vaccines of the routine program is completely in a private physician. So it's integrated into the routine, into the primary health system. So we at national level were completely absorbed by COVID, but of course, so at the primary level, the vaccination of children were still continued. What we have seen similar to Chile was a steep increase in especially influenza and also pneumococcal vaccination in adults, which is mainly a result of a large communication campaign. So actually for routine immunization, because it's more decentralized, we don't have a big communication campaign for our routine program. But now with COVID, we had a really big campaign now managed by the Ministry of Health. And what we see also, which is quite interesting, I mean, not only for our COVID vaccination, we have a acceptance of around 85% would like to receive the vaccine, the COVID vaccine in Germany, but we see at the same time an increase in the acceptance and the confidence of overall vaccinations. So we have a 2-year acceptance monitoring, and starting 2012, and we saw in 2020 the highest ever acceptance of any vaccination. So that's actually probably a success of this communication campaign. However, where we are not really good in Germany, we don't have a central register for our vaccine uptake. So we usually use the school entry investigations, and we have from health insurance claims data, but there's a delay of up to 6 months. But for routine immunization, that's often some kind of sufficient. But now we were forced with the COVID vaccination to build up from scratch a digital system to register these immunizations first in our vaccination centers, because we had now established a centralized vaccination and vaccination centers. Then there was in April the decision to move also to private physicians. So into the system, we needed to integrate more than 100,000 private physicians. And now we expand to company physicians. So we are vaccinating in big companies, which is again for our immunization uptake monitoring another step. So we are completely overwhelmed with these systems of adapting, expanding, and I would say 90% of our national immunization unit here is now involved in COVID-related issues. So I mean, we have some basic work on routine immunization, such as routine uptake monitoring and reporting, but almost all our staff are now involved in all these efforts around COVID, and where I also see less work being conducted, of course, within the NITAG. So the NITAG Secretariat is 150% absorbed in all the COVID-related topics. All other topics by the NITAG are actually on hold. So there will be a lack of 1.5 years probably that we will not be able to work on any other vaccines for national recommendation making. So that's a little bit what I worry in our setting here. Thank you very much.
Thank you very much, Ole. It's while you were speaking at the end, I saw all the panelists actually nodding. So I reckon what you're talking about is also an experience shared in other countries. Congratulations on your communication campaign, because nowadays seeing an increased acceptance of immunization is a major achievement. I mean, if I judge by what's occurring in France, in one of your neighboring countries, certainly the acceptance is not 85% all over. Actually, there's more resistance to immunization than before, and it's such an important element of the immunization program, the communication element. Let me now move a bit south, and I will continue the southern line before moving east. So I will first turn to Randa. If you are Mr. Immunization in Germany, she's Mrs. Immunization in Lebanon, and she's in charge of the primary healthcare department and managing the immunization and essential drugs program in her country, which is doubly affected by the COVID crisis and the political situation. So, Randa.
Hello, everyone. Thank you, Philip, for the kind invitation. And I really would thank also the presenter for the great presentation, the experience of an experience from South America and from the African region. And as well stated by Dr. Richard from the African region, that routine immunization coverage stagnated the last decade and expected to drop based on data, 2021 data, while outreach and fixed immunization sessions are affected by COVID-19 pandemic. Also, as Magdalena has well stated and concluded, that routine immunization demand decreased in Chile compared to previous year, where Chile health authorities maybe could, and through coupling existing vaccination activities, namely the influenza program, could make up and recover some of the missed children. I could also confirm that this fact in the Middle East also, this is a fact in the Middle East, where Lebanon is witnessing a drop in routine immunization coverage by around 21%. The burden of COVID-19, together with the, as Philip has mentioned, together with the economic situation, is placing further challenges on the uptake of health services in general, and particularly the routine immunization services. So in Lebanon, we could maybe make up in part and recover for this through national immunization campaign that were planned for the year 2019 and were delayed till postponed till 2020. And this was mainly MMR and polio campaign. And in addition to the strong partnership with the private sector, and as Ole said, the case of Germany, where the private sector continued to absorb actually the routine immunization in a way. Also, the presence and the existence of a well-functioning primary healthcare network, again in partnership with the NGOs, has helped a lot. So as we can see that this is global, and as parents around the globe cancel child checkups to avoid coronavirus exposure, a primary healthcare emergency and another health crisis is inadvertently in the horizon. And talking about outbreak of vaccine preventable diseases as the collateral damage of COVID-19 outbreak is a great worry. So the problem is global. Immunization program in more than 24 countries have been suspended, which could leave more than 100 million children vulnerable, according to WHO and UNICEF consortium. So as we are well aware that the optimum rate of coverage for many vaccines, known as herd immunity, is about 90 to 90%, this is really dangerous. So I could, from my point of view, understand that parents focus on the threat at hand. However, this should not be the case of health systems and pertinent international organizations. The role of healthcare providers is also key, where it's no longer suffices to say clinics and health outlets are open if parents want to come in, versus you should come in as parent, because this is really crucial. There are responsibilities that parents should assume, and this maybe should be targeted through effective communication strategies. So we should understand what is keeping parents from getting their child vaccinated, and let's solve it. What is affecting, you think, their attitude and their hesitancy? Don't you think, and these are questions to all of us, to Magdalena, to Richard, to the maybe participants, what is affecting the attitude and the hesitancy of the parent? Don't you think that junk media is affecting? Don't you think that infodemic is more dangerous than pandemics? Don't you think that irresponsible political debate that key leaders are running on media is really affecting parent confidence and hesitancy? Don't you think that competition among pharmaceutical companies is affecting? Don't you think that loose position and lack of solid position of pertinent bodies, being national or international, is also affecting? Don't you think that lack of efficient communication strategies is really affecting? So I think that it's time, while people are struggling to get their COVID-19 vaccine, to raise awareness, to decrease hesitancy, to stop political interference, and to keep politics away from health, and to rebuild the momentum through integrated primary healthcare-based service delivery of routine vaccination, to make really parents recognize how devastating infectious disease could be, and to perceive that vaccine are the only way out. So this is what I can at least think of while hearing you presenting and while hearing the comments from different regions of the world. And I hope this could help maybe take the debate further, if not in this session, in further sessions. Back to you, Philip.
Thank you very much, Randa. And I reckon indeed your questions were mostly rhetorical questions and affirmations. And the issue is how we can change the paradigm in the future. So rather than asking panelists to answer and state their view, let me move south and turn to Moses Simuyemba, who is an evaluation and public health specialist, and is the head of the Department of Community and Family Medicine at the University of Zambia in Lusaka. And he has actually been recently involved in a Gavi country evaluation and focusing on the impact on the COVID vaccine, if I'm not mistaken. So Moses.
Thank you so much, Philippe, and thanks for the opportunity to be part of this. Thanks to the presenters, I think very enlightening and interesting presentations. A lot has been said by even the panelists, so I will not repeat much, looking at the time as well. Yes, Philippe, as you've said, been part of the Gavi full country evaluation team for the past 6 years or so. So this year we were focusing on sustainability issues around immunization, and of course, COVID came up and we included it in the evaluation for the year. Just to say the report is almost final. I'm sure Gavi will have it on their website in the next month or two if anyone is interested. So on the COVID, I think a lot has been said. I won't repeat. In summary, yes, both routine and rather outreach and health facility services have been affected quite a lot with COVID. And one may not expect that in settings that have not had huge statistics of COVID like we have. So as part of this, we did the national level and sub-national level data analysis and gathering. And we found that even in places where, you know, there were very few cases of COVID, because of the general atmosphere in the country and information and directives from Ministry of Health, for instance, to avoid gatherings and so on, people were kind of reluctant to go to health facilities to seek these services. So there was general disruption of these services. I will point out just one or two issues that maybe did not come out from the other presentations. And one is about HPV vaccine. I think there was a mention in Chile about HPV vaccine, but not in a lot of detail. So one of the things that is peculiar about HPV vaccine is that in a lot of countries, it's delivered through schools to target the appropriate age group of usually 9 to 14 years old. And what we found here in Zambia, because it's done in campaign style once a year, is that the schools were closed. So that's a major disruption in terms of how do you capture this target group that you've traditionally captured through the schools, and now they are all scattered around. You know, some are in boarding schools and so on, so they live in different areas. It's very hard to capture them. So for HPV vaccine, I think it's a challenge, and there's a lot of debate around HPV vaccine in terms of what's the best way to deliver it. Is it through schools? Is it through health facilities? Is it through routine ways, or is it through campaigns? And so COVID has sort of exposed some of those issues. If it's through schools and we rely totally on that, what happens in such situations? Maybe we need to strengthen the other modes of delivery, such as the outreach and the health facility models for HPV vaccine. So I think that's one I wanted to point out that maybe has not been covered by the others. The other thing was touched on briefly, but I think partner participation in immunization programs in resource-poor settings like ours is very strong. And COVID, you know, a lot of them had to work away from the office. Some closed the office. So that's a big gap in the immunization in terms of that partner support, whether it's technical assistance or financial support. When partners are not able to work due to COVID, that affects the performance of the country as well. So I thought I should also point that out. Lastly, it's in terms of vaccine hesitancy. I think in settings like ours, where you have a new vaccine like HPV coming on the scene, for instance, that is pretty new, and then there's COVID issues and so on, there was a lot of misconceptions around, well, maybe they're using this new vaccine to actually give us COVID. You know, so such things do happen, and it speaks to the issues that we need to strengthen community outreach and mobilization and messaging, which in resource-poor settings, unfortunately, because budgets are so minimal, it is usually the most underfunded aspect of what is done. But in times like this, you realize that that really needs to be beefed up and strengthened to avoid such things. So that's all I would like to add in terms of that. But I would like to say that all the findings really point to the fact that our Gavi findings were also in line, and it's good to get confirmation from other countries and regionally that this is actually the state in terms of most countries. That's all I have to add. Thank you so much.
Apologies, I was mute. Thank you very much for this very interesting contribution, Moses, much appreciated. Let me turn now east and move to Gurinder Singh, who is a person with an incredible wealth of public health experience and happens to be the state immunization officer in Punjab in India. So that's one state, but one state that's probably bigger than many countries. So Gurinder, I know the situation is certainly not easy in India these days with the real upsurge of COVID and the tragic accumulation of death. Do you want to comment on the impact on immunization?
Yeah, good evening, everyone, and thank you, Philip, for giving me this opportunity to participate in this important panel discussion. Yeah, it has been pointed out rightly by the presenters as well as my co-panelists earlier. COVID-19 has definitely affected almost all the health-related activities. All the non-COVID activities, they have been affected as elsewhere in the world. It has been affected in India as well. And if I talk particularly about Punjab, one state in the northern India, yes, definitely it has caused a lot of inconvenience to the people. It is for the last almost 2.5 months since we had the second upsurge, the first one being in 2020. During the second upsurge, all non-COVID activities in the major hospitals, they were put on hold, and it was only COVID. And in Punjab, we had almost 10,000 cases a day, and when the country was also having more than 400,000 cases per day. So as far as immunization is concerned, during 2020, we were quite comfortable and we were able to maintain the immunization activities since the number of cases was not too high, as well as the penetration of COVID into the rural areas was not much. And here in our state, at least, and moreover in the rest of the country as well, its condition is the same. that we were able to continue with our immunization activities, because the outreach as well as the fixed base activities, we were able to do them quite effectively. But then as the COVID-19 situation worsened during the current year, during 2021, when we started having more number of cases, when the real face of this pandemic started showing up, we had to stop all activities. And then when the vaccination also started, although all the healthcare providers who were involved with the routine immunization program, they were not involved in the COVID vaccination. But sorry, but at the same time, due to this COVID vaccination, as well as due to the worsening of condition, the lockdowns, so all these things, they did make an impact on the routine immunization services, thus leading to some decline in the routine immunization coverage. Although we in Punjab, we had a very good routine immunization coverage of more than 90%. But recently, I have seen that there has been some decline, but I'm afraid that once this pandemic is over, I don't know how long we are going to get back the immunization on the rails. It might take some time before we reach the same levels as we have been having in the pre-COVID era. But as Mihigo also pointed out in his presentation, that the resilience of the resilience of the health systems, that shows how how we respond to the situation as it arises. So I do believe that here we have quite a resilient healthcare system, and we would be able to reach our pre-COVID era situation pretty quickly. But keeping our fingers crossed, we don't know how many more waves of this COVID pandemic are going to be there, because having experienced 2 waves till now in the state, and looking forward to another wave, which is likely to start pretty sooner than we might expect. Nobody can predict that. But at the same time, when we look at the COVID vaccination, yes, it has been progressing well, although we had a slow start. In the beginning, the people were quite skeptical. They were not ready to come forward. Even the healthcare workers, healthcare providers, the frontline workers, even they were afraid of getting the COVID vaccine, which I believe occurred almost everywhere in the world. But once it started, now it is the people are coming forward. The people, they are queued up to get the vaccine as quickly as possible, because now they have understood that probably the vaccination is going to be a quite effective in prevention of COVID, and if not exactly the prevention of disease as such, at least in preventing the serious disease. Of course, that would be quite possible. So I would like to agree with all the other panelists that yes, the COVID-19 has definitely affected the routine immunization services adversely, and we do need to look into it. We do need to think about how best we can continue to provide the immunization services, because the biggest fear with this decline in routine immunization would be the increase in the VPD outbreaks. So if that happens, combined with the COVID pandemic, that the situation can become quite alarming in some of the areas. So this is one of the important fears that we are looking at. Thank you so much for giving me this opportunity to be a part of this elite panel. Thank you so much.
Thank you, Gurinder, for these important comments, and we certainly hope that we won't go to this outbreak situation, and that in many places they are probably currently contained by the prevention measures that apply broadly. but who knows what will happen. So we wish you the best. It's striking to me also, you mentioned the reluctance of the healthcare providers to accept the vaccine, which is not corrected, but we have seen that in certainly in many countries. Let me go further east then to ask Wong Vu Min to provide some comments from the perspective of Vietnam, where he's a senior program officer working for the program for access to technologies in health, PATH. So please, Wong Vu, give us your viewpoint.
Thank you, Philip. Thank you to presenters. I think I learned quite a lot with two presenters because Magdalena is still here, so I would like to touch on the COVID-19 vaccine first. And you might know that with low-income country like Vietnam, so far we have access to about less than 3 million doses of COVID-19 vaccine for about 100 million population. And about just less than 2% of population without vaccinated. So it's far, far from high-income countries, I would say. So we haven't seen much, because before COVID-19 vaccine introduction, we a bit focus on, let's say, how to minimize the negative impact of the burden of the COVID-19 vaccine introduction, because it's huge demand for Vietnam. It's 100 million. We never got that kind of big target cohort for immunization. So we tend to think about how to minimize the negative impact. But it's quite encouraging to hear Magdalena's presentation. So now I thought that it's not just a challenge, but also the opportunity for, let's say, either booster or strengthen the routine immunization, rather than we just think about the negative side of COVID-19 vaccination in terms of giving more burden to health system, while in low-income country it's weak already. So that's very encouraging when I hear the presentation. And for us, it's very early stage. We only give vaccine inside hospital, so the burden we haven't seen much, with just about 1 million people vaccinated so far. But we already observed the vaccine hesitancy, and some group, even they are in the first prioritized group, they refuse. And because the very short expiry date of the COVID-19 vaccines we received, so some hospitals decided that they give vaccine for all of their health staff and their family, instead of waiting for that expire. So that we need to address in the long run. But I really interested in the idea of when I saw Magdalena present that the demand for vaccination with other vaccine even increased after vaccine COVID-19 vaccination, is really, really interesting points we should learn, and we might try to, let's say, now we try to, let's say, taking advantage of COVID-19 vaccine introduction to boost the routine immunization. That I think could be the point for us here in low-income country to start to think about taking advantage of resource allocated for training health worker, for mobilizing the human resource. In Vietnam now, we mobilize the medical students, we mobilize the recent retired health staff to come back to serve for COVID-19 controls. So with that regard, I think not just negative side, but also very positive side in terms of putting the burden into the health system. Regarding to the impact of COVID-19 disease, it's interesting to me to hear from African country as well. With more or less 50% of countries have disrupted in immunization. It's very encouraging, I think. And Richard already mentioned that with resilience of immunization system and with measures for preventing the negative impact, that is encouraging, you know. So even in the very challenging situation, if we have a good system, if we have good measures, we can minimize the negative impact. So that definitely a good lesson learned for us, not now, but for the future as well. But something I also would like to share is you know, in Vietnam in 2020, we only have one or two small outbreaks in some provinces only. Not many cases, just a couple thousand cases in 2020. So we didn't really experience with how negative impact is the health system. But you know, this year with the surge of COVID-19 in Asia, and Vietnam is not out of that wave. And we start experiencing with the pressure from COVID-19 cases. And now more than half a province in Vietnam under COVID-19 surge. So it's huge pressure. And but we learned from 2020 when we locked down the whole country, and of course the immunization program suspended the whole country for a month or so. But now we learned from 2020. We just try to select locking down the place with the outbreaks rather than to fear of the COVID-19 pandemic and then you lock down the whole province. No, now we selected even lockdown to communes in district or district in province. Almost no province with the whole province locking down. So in that way, we still can somehow sustain the immunization programs. So just a couple points I would like to say. The time is up. So thank you so much for opportunity to learn, also to share experience from Vietnam.
No, thank you very much for this good point and your optimism, hopefully that we can bring a positive legacy of the crisis. Certainly, I've never seen talking about immunization as much as now. I'm conscious of time. A couple of the panelists had to go already. I know that you're all pressed by time. There were 3 questions, perhaps if I can take one or a couple of these very quickly before we close. But there was one question, I guess, from Judith Perez. Could we go back 12 months from now and with what we know today and what would be done differently? I'm not sure if any of you would like to take that question. I think it was lined up when Richard was presenting. And I think several of you, like he did, emphasize the resilience of these some immunization program. But would one of you like to volunteer some reaction to this question? It's a challenging one, and perhaps.
Yeah, I'm biting my tongue because it's really difficult, you know. I think yes and no. I mean, all through these presentations today, there are good and bads, and we've learned a lot. And you know, of course, we could have planned the massive rollout and be prepared for the COVID-19 vaccine rollout earlier, but we didn't know if the clinical trials would succeed, right? So it's really, you know, yes, we could have been 3 months ahead. We could have planned a little bit ahead, yes. On the routine immunization, I think this is, it's also good and bad. I mean, we have seen that the impact was there. I think every one of us in immunization were having that as reflex. Then when the pandemic hit, this must, you know, affect essential health services. It just must do. And maybe sending out the messages much earlier. SAGE did a strong statement on maintaining and restore immunization early on in March, April. But still, you know, could we have been one month ahead with that strong message to all? and convene earlier, maybe we'll do that next time. And the good in this time is also, building back better and using all the resources that we have in COVID-19 vaccine rollout to build back better and stronger. The digital tools Ole is talking about, that work is not for nothing. You can use that probably as a platform for next time or for other vaccines. The logistics systems we have, the COP, so there's cold chain equipment that is now being channeled to many countries. A lot of things will be staying beyond and can help to build back better, right? So yeah, maybe we could have. It's difficult. Always easy to say that now,
Right, very challenging. Gurinder, you would like to volunteer a comment?
Yeah. Last year, when this COVID-19 pandemic started, I was not at the state headquarters. I was not director of health services at that time. I was working at the district level where I was head of the health services again. Our first and the foremost thinking at that time was that at least the routine immunization should not suffer. We must take care of our mothers and the pregnant women and children. So that is being the first casualty in any pandemic or any health situation like that, because they are the worst sufferers in any condition. So we made all efforts to see that the pregnant women, the mothers would be, and the children who are born during the pandemic, they don't suffer. If we look at it, that what we could have done better at that time, nobody ever thought that there would be so many, the pandemic would be coming time and again. It started sometime in December in India, end of November or December. January, we had the first cases. And we were all hopeful that as the summer sets in with the rising temperature, the virus would go away. But then now we see that the story was not that easy. So it has sustained itself. It has remained during the peak of summers. And as the monsoon set in, the rainy season came up. So it was still there during the next advent of next winter. It was at the lowest ebb. And then suddenly in February, it starts rising again. So even after more than 1 year of the pandemic, we are still looking at what next. So I believe whatever we could do, we have done the best during the last 1 year. And there is no doubt we have learned a lot. We have had our good as well as bad experiences. We had our experience, we have our challenges, and we have overcome all those challenges. And what I would now look at is that in the coming days, how best we can sustain our routine immunization services so that the children who have lost their vaccination in between due to any or whatever they have lost, that we need to regain over the next few days as the number of cases has gone down drastically, and we are quite comfortable as of today. And this is the time when we need to look at our non-COVID services, and we need to look at our routine immunization and other services as well.
Thank you very much. Magdalena, final comment, and then I will close this meeting, and with apologies for those questions that we cannot air because of time. So Magdalena, final word.
Just briefly, we have to remember that immunization services and immunization demand belongs to a health system context, and itself the health system to a social and national context that has been hit by the pandemic in different dimensions, socially, economically. So there are many factors that to be analyzed that might have impact the immunization, the routine immunization demand. And I believe that this difficult question that we are trying to comment on, because we're not answering it, I can link it to Rada's questions, the list of questions where she shared with us. Lots of elements that are impacting our services and the distributions of vaccines, etc. So I see the link between that. What could we do or have done much better with the questions that Randa shared with us? Over to you, Philip.
No, thank you very much for this making this point and connection with the challenges raised by Randa. So. Unfortunately, time is flying. I need to close this session. Thank you for your patience. Thank you to the two excellent speakers, to all of you panelists. I mean, your interventions were great, and to all the participants. I want to also thank Carol Beresville, who always is in the shadow, but important element of the organization of our ADVAC alumni webinars. And I'm not sure what the next topic will be. We had talked about perhaps COVID safety. Maybe it's even too hot a topic these days. I'm not sure when we will have the next webinar, but I wish it would be in a presential meeting. We will keep the dual mode anyway in the future of having also a Zoom component allowing for more participation. But I hate to say, but I suspect our next webinar will still be only a virtual one, because I see a few months before meetings can resume. I was hoping that SAGE and in October would be taking place in presential, but I very much doubt it. So we'll see. So thank you to all of you, and best of luck with the situation in your respective countries, and goodbye then. Thank you.
Thank you, and bye-bye.
Bye.
Thank you.
Thank you, Philip. Thank you all.